Good afternoon, everyone.
Good afternoon, sir.
Good afternoon, sir.
Good afternoon, sir.
Good afternoon, Dr. Alok.
Good afternoon.
Good afternoon, sir.
Good afternoon, doctor.
Nice to see you all after a long break. Today we are going to discuss something very, very important. First of all, I want to tell you that there is a new form of new approach for autism, which I was working for last 3 years, and it is the summary of whatever I have learned for autism, and that I have named as interdisciplinary holistic approach for autism, IDHA. And we have recently got the patent for it. We were waiting for the patent for IDHA. So some of you might know this also, that I have discussed in the previous sessions. So we have got the patent for IDHA now. That is a new approach which we have developed for autism. And today we have kept this special session for giving you brief about IDHA, like what is the approach. And in our research, it has given us wonderful results. Though I've been working on developing this approach for 3 years, but I have been using it for almost 7-8 years now. Okay, so it is the outcome, it is purely from the experience which I'm going to share today. Not much in detail, but because the time is limited, to know the entire approach, we require more time, long sessions. But today I'll just give you a brief about what IDHA is. And later on, we are planning to come up with, now the team is working on it, a full-fledged training program for IDHA approach. We are coming up in 2 levels. Level 1 is for open for all parents and professionals and anybody who wants to understand. And level 2 is for master trainer program. So we want people to get trained on it and then spread across through training people and through supporting different centers. So we are working on that. We'll soon come up with that. So let's begin. I'll just start my presentation first. I hope the audio is clear.
Yes, sir.
Yes, sir.
Yes.
Great. So concepts are the same. You all might have heard those concepts before. There is nothing new in it. I would not say that it's a research or it's like not, it's a therapy. IDHA is not a therapy. IDHA is just a approach which clubs too many other approaches and goes scientifically as well as research driven. So today we are going to talk about interdisciplinary holistic developmental approach, that is IDHA, for autism management. It is integrated assessment, therapy, and parent partnership. So as you all know that without involving parent in the developmental approach or for autism, it is very difficult to achieve the success. Yes, we can achieve success, but when we involve parent, then we can multiply it to a very good number. So this approach says it is integrated assessment, which I have always been talking about. Children are going to one occupational therapist at one place, and then the speech therapist, and then behavior therapist, and then other professionals at different locations. But these professionals do not have coordination. Even if it is in a multidisciplinary center, I am seeing that there is no coordination. Everybody is doing their own assessment, and then they are starting their own goal plans, goal sheets, and they're working. I completely understand that occupational therapy is totally different than speech and language therapy, or it is totally different than behavior therapy. But yes, the goals and the management for autism, when it comes specifically, it is interrelated. So here in IDHA, we talk about integrated assessment, integrated therapy, and parent partnership. These are the 3 main areas which are included in IDHA. So as the name itself says, interdisciplinary. So all the disciplines, all the therapies are clubbed together. Holistic, overall development. We don't talk about development in one area, one domain. Okay, so we don't think that if only the speech and language, because many of the parents come to us and then they say, if my child starts speaking, everything will become normal. They have that notion that, okay, it's just with the speech and language, but it's not with the speech and language. It is with speech, language, communication, cognition, all motors, all the areas should be taken care of along with yoga therapy. So the entire program, if you see the autism specialist program which we run, is based on IDHA actually. But so far, since we didn't have the patent, we were not naming it as IDHA program, and now it is going to convert, and we are going to go more deeper into the IDHA approach, and it's going to convert into that. So IDHA is a united framework for autism management. It says development over diagnosis, connection over correction, and independence over compliance. So in IDHA, we focus on development, we focus on connection, not correction. We don't keep on correcting the child, but we focus on the connection with the child. And also, more than compliance, we focus on independence. As per therapies, in therapies, we focus on diagnosis first, and then we plan the therapies, and then we work on corrections. We find out wherever child is going wrong or child is doing weak areas are there. We take those weak areas and we start working on them. And then we follow our protocols. We go as per the compliance. That is the therapy model. Now, IDHA approach is totally opposite to that. Though it is using therapy, without therapies, IDHA is also not possible, because IDHA itself is not a therapy, it is just an approach. So it is saying that we need to focus on development of the child, irrelated to the age. Now here I am giving you a concept. So far we have been seeing child milestones related to age. 3 years child should do this, 6 years child should do this, 10 years child should do this. And that's where the major stress is. Child's age is growing, child is not able to do things, child is not able to cope up, stress is increasing. Therapists are increasing their stress, parents are increasing their stress, and this stress is downloading to the child, because you are child environment. Be it parent, teachers, special educators, therapists. What is child environment? We all people are child environment. Child moves around us. And if we are under stress, definitely that stress travels to the child, because age is a number which is growing every second. And with growing age, if you are relating development with growing age, in autism, we fail. So I am trying to deassociate age from development. Development in a child can come at any age. Before 7 years, 6 years, like before I started practicing for adults, and we started this Spandan, we started just 3.5 years back. So before this, say until 2018-19, I was also of same thought that once a child is 12 years, 13 years, 14 years, we can't do much changes, much development. We can just work on functional goals, or we can just work on their vocational training, but we cannot make much of the changes. Have you realized autism? You see how many pediatric rehab centers are there. These children come to us at the age of 2, 3, 4, 5, 6. And then they are with us in the therapy units till the age of 11, 12, 13 at the max. Not that all children overcome the symptoms of autism. We have to accept it. But where do these children go? After 13, 14, where do they go?
Most of
Yes,
most of them go to special school and back to home.
that's it. Back to their home. The special schools also have a limit of 16, 17 years, then back to home. Yes, Sudha ma'am?
At times I feel scared when we think 10 years down the lane, what is going to happen to this child? It's a big question mark, in fact.
Yes. So IDHA approach says development can come at any age. And I have experienced it. I have experienced it with a 16-year-old child who was totally non-verbal, very, very hyper. Cognition had not developed, 100% dependent, even for toilet, even for daily necessities, even for feeding, he was dependent. And now at the age of 18, almost 18 now, February he'll be 18, he is very close to independence. Not totally independent, but in ADLs, he is very close to independence. So he is cleaning his clothes. He's taking baths, toileting, wearing own clothes, folding them, washing them, and then cleaning his vessels, eating food on his own, serving on his own, and cleaning the table, and all those things he is doing. Basic necessities he is able to fulfill just in 2 years after 16 years. Till 16 year, child is underprivileged and he didn't have much access to the therapies and all. So till 16 years, mother used to run behind child with a stick. She used to treat the child as an animal, and she used to feed. Child was feeded by mother. So all of this, and the behavior was really very, very aggressive, but things have gone smooth. I have seen the similar development in a child who is 29 years. Another is 31 years. So with this IDHA approach, we are seeing miracles happening. Some of the professionals who know us and who have referred these children to us, say Dr. Pooja Vajratkar, Dr. Kanan Doshi, these children, these professionals, Dr. Gargi P. Sinha, they have told us, they have given this compliment to us that some miracles are happening in Spandan. So those miracles are happening because of this approach, which I was working on. We were practicing it also. We are practicing it. And today today is the day because we have got the patent now. So today I want to share this approach with you all. So let's look into what exactly it is. Before we begin, I want to clarify. IDHA is not another therapy technique. I have already told you it is a way of thinking, planning, and working together. So it's just a different way of thinking and handling these children, planning for them, and working together, all professionals and parents. Let's leave our competitiveness aside. That okay, if I'm an occupational therapist, if this child goes to this speech therapist is connected to another OT, they will send the OT to that therapist. This all we should leave aside because demand is really high. If we are able to bring change in a child, I'm telling you, even if we are in outskirts of Mumbai, we are in a village at Spandan, and we have parents who are willing to come to us even from 100 kilometers. There are parents who are inquiring and saying that we can come and stay there, we can relocate there just for the therapies. And I've seen parents coming from UK to Goa. Many of Goans who are settled in UK only for therapies, they are coming back to India because getting appointments and is very difficult there. So they are coming back to India. So parents will do anything if they will come to you, even if you are in a very competitive zone or in a very remote location. They will come to you if you have the right approach and if you can bring development in the children. So leave aside your competitiveness, connect with other therapists wherever the child is going, understand from them what they are doing, what are their goals, integrate your goals with them. So it's a way of thinking. And then plan from strength point. Most of the time when a child comes to us, parents will talk only about their weaknesses or challenges because those are matter of concern. We also write down matter of concerns. Child does repetitive talking, child is spinning, child is mouthing, or child is whatever. We just keep on writing that. Leave them aside. Just focus on what child does, what child is good at, what are the child's strengths, and catch hold of those strengths and work together with parent. Train parents. Do not be worried. I'm just sharing it on an open platform here because I believe you all are very well connected to me and you will understand the essence of what I'm trying to say. It's little contradictory statement. People, professionals might oppose me on this, but I feel you all are family, JKP Care Foundation, and you all are connected and we all are family. That's why I'm sharing this. I'm saying this, that parents, we don't have to worry that if a parent gets, some of us, we do that. Even in my earlier age, I am saying in my earlier career, I used to think that also. I also used to think the same way that if this child has, parent learns the techniques, then why would parent come to me? Parent would do therapies at home. We have that worry. We are also the professional parents who are here. They should understand that this is our bread and butter. We are giving our full time in this field to earn money because we also have families to run. So we have to think from business angle also. But trust me, once you start working with parents, your earning becomes double, immediately double. Parents have better connection with you. You see more development, faster development in children, and you get more referrals from word of mouth. And word of mouth referrals are the best referrals. You don't have to convince them, you don't have to show them big infrastructure, you don't have to spend on them or marketing, nothing. Just word of mouth. So it's a way of thinking, planning, and working together. Autism management is often fragmented. One therapist works on behavior, another on speech, another on motor skills, while parents are confused and overwhelmed. They go here, they go there, this therapist is saying something, another therapist is saying something else. Sometimes their statements are also different, and parents are confused and they are overwhelmed. They are worried about child's future, they're worried about, they want to see the development fast, they want their child to, because the age is growing. They have this back of the mind, my child is 5 years. They compare their child with the other children who are of 5 years. Because it starts from diagnosis. In diagnosis, we compare with age. And from there, we start everything with milestones, with age milestones. I am saying in IDHA, we need to compare with milestones, milestones of development, but not age milestones. We should think of chronological age, developmental age rather than chronological age. Chronological age is the age as per calendar. So we should think of developmental age. What is the developmental age of the child? And child should grow in developmental age. Otherwise, calendar age is just a number. Some of you here are 40 years, 50 years, 60 years. Some of you here maybe 20 years, 21 years, 22 years. May God bless all of us with long, healthy lives. But we never know. Calendar age. Maybe I have calendar age of how long I'm going to live. Maybe I'll die at the age of 50, and somebody else here who is 60 will continue living for next 30 years. And I'll die after 5 years. So calendar age is just a number. We do not know when it is going to end. But developmental age we need to focus on. So IDHA brings everyone onto one common developmental path. We look at the child holistically. Brain processing, emotions, regulations, strengths, interest, family dynamics, and real-time functioning. So we look on all these things together, holistically. So why IDHA? What problem it is solving? Well, therapies are going on, autism, we have beautiful approaches already. So then why we have to think from a different angle? Why we have to go for this? So the current challenges in autism management are fragmented therapies, scattered therapies, fragmented therapies, conflicting professional advice. One professional has different opinion, another has another one. Age-based unrealistic expectations, I have just now explained that. Over focus or on behavior suppression. Major focus is on handling behavior. A child is doing social non-acceptable behavior and we just try to focus. You speak to any parent, they are still okay if child is not speaking, but behavior is the major problem for them. Initially, at very initial levels, behavior is not major issue. Major issue is speech and language for parents. But as the child grows, they accept the delay in speech and language or communication. But behavior is something which they are really worried about, because then they have to lock the child at home. They cannot go out also themselves. They cannot take the child out, and they have social stigma. All those concerns are there. Parents' confusion, guilt, and burnout is still there. So in current approach, whatever approaches we are using, the way autism management is going on, these are the major challenges which we are facing right now. IDHA responses, IDHA provides a single unified developmentally grounded system that aligns all stakeholders. So we first of all, initial level itself, we align all the therapists and parents together. So conflicting professional advice is not there since all are aligned together. Then centers the child nervous system. So we don't work on the age, but we work on the developmental age. Empowers parent and translates therapy into real life independence. So we work on independence of the child rather than milestones, development. We go more towards the independence. How many of you feel autism management is currently fragmented? How many of you agree with me? Anyone who wants to share?
Sir, can you please repeat the question?
It is on the screen. You can see the screen, right? How many of you feel autism management is currently fragmented? It is scattered. The autism management approach, what we are using these days, the parents are running from one place to another place. They are getting different opinions. Fragmented is like it is not connected with each other. It is not one single approach. Like,
Absolutely.
yeah,
Sir, can I say absolutely? I think it is fragmented because the rising competition between different child development centers, they are busy in their own competitions, and hardly anyone is thinking about the welfare of the child. So there is growing that insecurity among these child development centers about with respect to each other, and the parent is totally confused. He doesn't know who to trust, who is actually, they are continuously asking the professionals to tell them when will their child be when will he talk, when will he be able to do his own work, when can I expect any change, and they're just beating around the bush. They are not showing, nobody's showing them the correct path. No, recently I saw a person, he was not very well educated, and his child is 8 years old, and he has not been referred to a psychiatrist. 8-year-old child is taking medicines for schizophrenia. He has only been to neurologist, and not a single neurologist has asked him to visit a psychiatrist. So there's a lot of fragmentation everywhere. So you're muted.
You are not muted, but we are not able to hear you suddenly. No, sir, we can't hear you.
now am I audible?
Yes.
The mic battery went down. I'm
Okay.
speaking since morning today, so okay. So yes, rightly said that parents are confused and the autism management currently is fragmented. We don't have the integrated approach, which is missing. So, and guidance-wise, we don't have specific guidance protocols for parents that this should be stepwise, that okay, we need to first build the acceptance, and after acceptance we need to show them the framework, future planning and everything. So there is no proper guidance mechanism or protocols developed for that. So why autism needs a holistic developmental approach is because autism affects multiple domains. If we go for like you go to the multi-specialty hospitals, if you go for one concern, say somebody has some heart blockage, they go to the cardiologist, and the person has diabetes also. So the cardiologist will connect with the diabetologist before planning the intervention, before planning they will connect, they will speak. If the person has multiple other concerns, say some concerns with kidney and some concerns with other issues like lungs issues and all, they will connect, and they develop the interdisciplinary, they use the interdisciplinary approach, and then only they plan if they have to operate or if they have to plan any angiography, angioplasty. They do this. This is a regular practice. But in autism, unfortunately, this is missing. Autism is affecting multiple domains. Autism is not affecting just the behavior or just the gross motors or fine motors or just a speech or just cognition. So it affects multiple domains, and we need an approach which is interdisciplinary. Fragmented therapy centers confusion, yes, creates confusion. So yes, fragmented therapies are there. different therapists are practicing individually. There is no connection. Even in one, I have seen that even in the multidisciplinary centers also, like a therapy center which provides OT, speech, and behavior, all three of them. I have seen professionals, they come, they take their sessions, and then they go back. There is no interaction among professionals. They don't even interact about the child, or they don't share their goal plans. So that is something that creates confusion. Development happens as a whole and not in parts. So development is not that child will just develop one area and become perfect in it. Until I develop the gross motors, fine motors, until I develop then if my motor movements are not proper, bringing speech is also difficult. If my cognition is not proper, communication is difficult. If my behavior is not settled, if I'm not able to settle the behavior, then also your motor movements, child will hit. No matter you have good motor movements or concern, but child will use them in behavior, child will hit badly. So all of these development, what happens is as a whole, not in parts. As child, once there is a baby is born, infant baby, you think about 0 years or 1 year, 0 day or 1 day or 2 day baby, and see the development in the natural way of development. Different parts of the body grow together, different areas child is developing together. It's not that child's first of all hand will develop and then legs will develop, or ears will develop and then nose will develop. No, all of them, they develop together. So development happens as a whole, not in parts. Autism does not affect only speech or only behavior or only learning. It affects how the brain processes information. Major concern in autism is brain processing, how the child regulates emotion, how the body moves, how the child connects socially, and how learning happens. Unfortunately, many children experience fragmented intervention, that speech goes here, behavior goes there, academic pressure somewhere else, and child is confused, parents are confused. To address this concern, we have this approach which we have developed. So what happens? The child becomes overwhelmed. Yes, child goes for different therapies, different things are happening whole day. You see how busy these children are. Compare the life of a child with autism whose parents are very active and providing all therapies. Compare the life of this child with other children, neurotypical children. You will see how busy these children are. They are overwhelmed. They are going to the school, they are coming back, then this therapy, that therapy, very structured routine. So they become overwhelmed. Parents receive conflicting advices, yes, and progress becomes slow or inconsistent. A child does not develop in compartments. Development happens together. Emotions, influence, attention. See this, the role. We work on attention building activities for attention, but without developing emotion, you keep on working on attention. But if child goes into different emotional stage, whatever, no matter child has good attention span, but if child is into some emotional stage of stress or depressive emotions or sad emotions, definitely the attention is going to get affected. So then you will say, I work so much, child's attention is good, but right now child, because emotion part is missing. Regulation influences learning. Connection influences communication. So if I don't build the connection with the child, I am not able to build communication. I am able to speak with you all with my open heart, whatever it is, very openly today, because I'm connected with you all, directly or indirectly. You all are connected with JKP Care Foundation. I'm connected. We have interacted in previous. So I'm able to have that communication with you very openly. Would it have been another platform, a regular webinar where unknown people are coming? My way of speak would have been different. You communicate with your relatives, you communicate with your friends differently, or your communication is more with them. So connection, if you don't have connection with a stranger, your communication is less. So connection influences communication. So IDHA exists because autism cannot be managed in isolation. It must be understood and supported as a whole child, whole family journey. Not only the child, but the family. Not only parents, the entire family gets affected. So what is IDHA? Interdisciplinary, holistic, development focused, and strength based and functional. So let's clearly define IDHA. IDHA stands for Interdisciplinary Holistic Developmental Approach. Interdisciplinary means we do not work in silos, we don't work separately in isolation. Therapists, teachers, and parents share one vision and one plan. So the first thing is that we need to connect all of us. Leave the child aside. All three, therapists, teachers, and parents need to connect and share one vision for the child and make one plan for the child. Holistic means we look beyond symptoms. We look at the child's body, brain, emotions, relationships, environment, and family system. Because this everything of every domain affects the child's development. Usually in therapies, what we do is just look for body and brain. But here we look for family dynamics, environment, relationships, emotions. Developmental means we respect the child's readiness. So we don't go as per age, that 5 years child should do this. We go as per his developmental age. Developmental age is what? Till where child has reached and whether child is ready. If child is not ready for a school till the age of 7, calendar age of 7, I don't put the child in the school for calendar age of 7. I let him be prepared, let him be ready. So in IDHA we look for child's readiness. When child is ready to go for, yes, we support him in getting this readiness, but we don't force him. We don't just put him, okay, 3.5 years, put the child in school, child will develop. Sometimes it does more damage than the benefit. So we do not force learning, but regulation. And finally, IDHA is strength-based and functional. We don't ask what is child lacking. We ask what can this child do and how can we build from there. And we work on more on functional goals, more on activities of daily living. Start with that, ADLs, so that child starts involving. The core philosophy of IDHA is developmental age is better than chronological age. So we work on developmental age, teach what the brain is ready for. Connection before correction. So we don't start correction, we start with connection. Connecting with the child is important. Once you are connected, once you understand child's behavioral communication, once you communicate to the child in child's own language, you see that child connects with you and learns from you. Function over labels. So we don't go as per labels, but we go as per functions. Other principles, these are the 3 core principles. Other principles are emotion, drive, development. Regulation precedes learning. Connection is the gateway to change, and trust creates the readiness. Function over form. Life skills matter more than performance. Context creates competence. Skills must work across all environment. Now, this is one more thing which I want to share, that we don't just depend on one area or also only on the clinical therapies, but we work in all across our environment. Environment is physical spaces, clinic, home, school, public places. So in IDHA, we provide support, therapeutical guidance in all the areas. Also with different people, because people is also part of environment. And also with different material, that is also part of environment. So if a child has learned one skill, we practice the skill in all 4 environments of child. We practice it with all the people child is involved with, and we practice it with different materials. When these principles guide intervention, progress becomes natural and sustainable. So the first core philosophy, if I talk about, the first one is developmental age over chronological age. A 60-year-old child may function emotionally like a 3-year-old. Expecting 6-year-old behavior will only lead to frustration and failure. So at emotional level, at developmental level, child is at 3 years. So we should expect child to behave like 3 years and then build on that. Whereas we usually go with, oh, child is 6 years, child should do this, 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 this. And we try to pull. Just try to understand what I'm trying to say here is, it's like child is developmentally, child is at 3 years, calendar child is at 6 years. I am expecting child to be here. So what I'm doing is I'm pulling the child. And pulling creates tension. So if I'm pulling the child, child pulls himself back. Becomes difficult. What I do rather is, I understand the child is here. I keep target at 6 years. And then take the child, hold the hand of child, work on the strengths, take strength-based assessment, and then take the child to 6 years. Therapies are the same. All therapies will continue. I'm not saying that we need to stop the therapies. It is the approach we need to. All therapists should have this approach. That's what I'm trying to communicate. Second is connection before correction. A child will not learn from someone they don't feel safe with. Emotional safety always comes before skill training. So we need to connect with the child first. Once we can build that connection, learning becomes very easy for the child. And function over labels. Labels may help diagnosis. Yes. So when I am saying age milestone should not be checked, only milestone should be checked. For the diagnosis, we need to go as per standard protocol, age milestones. But once the diagnosis has happened, once we know that child is having symptoms of autism and we need to work on it, then forget the age, just work with the concerns, developmental age. So labels may help diagnosis, but function helps life. Our goal is not to reduce autistic traits. It is to increase independence, participation, and confidence. Because we all know that autistic traits come and go, come and go. Regression also comes at different levels of life. A child who has come out of autism symptoms at the age of 10 again exhibits symptoms of autism at the age of 16. Like we have IEPs, IEP you all might know, Individualized Education Plan. We also have ITPs, Individualized Transition Plans, for the children who are at 16, 17. So we give them ITPs because they again show the symptoms of autism. So autistic traits, because autism is forever, we all know that. So autistic trait may come at any age. But if child is independent, child has participation, confidence, child can overcome those challenges easily. So we work on independence, participation, and confidence. The pillars of IDHA, we have 6 pillars. Developmental readiness, that I've already spoken to you all about. Emotional regulation and connection. Please feel free to stop me in between if you feel confused somewhere. So second pillar is emotional regulation and connection. Third is interdisciplinary integration. Fourth is functional skill development. Fifth is holistic well-being. And sixth is family empowerment. So all 6 pillars we run together. The IDHA process flow is, okay, I'm giving you visualization of a therapy center where a parent is walking with the child after the diagnosis from a developmental pediatrician or clinical psychologist and saying that, okay, child has been diagnosed with autism. So first 15 days, we spend only for understanding. We don't start therapies right away. First 15 days, we connect with the child. We have two sessions simultaneously going on, one for the child, one for the parent. So all the therapists who are required for child, like say behavior therapist or ABA therapist or speech and language pathologist or occupational therapist, they will just play with the child. Flow time approach they use, they will spend 15 days one by one, say first alternate days one therapist is doing, or 3 days one is doing, and then 3 days another therapist is coming. They will do their own observation and understanding of the child. Meanwhile, our counselors would work with parent. For 15 days, parent compulsory need to attend those sessions which are with parents. So there we work with parent on counseling, on stress management, on future planning about the child, on not planning as such, but giving them a vision about the future and explaining them, empowering them, explaining them about autism. All of this goes on for 15 days. And child becomes friendly with the environment, center environment, friendly with people in center. Meanwhile, all these people, they do their observation. They get sufficient time to do observation. You take your child to an occupational therapist in 15 minutes. I have seen that. Not occupational therapist only, but we all. 15-20 minutes we spend with the parent, just look at the child, observe, spend, and just fill up the questionnaire, ask, just do the interview with parent and make an assessment, and then plan starts from tomorrow. Okay, bring the child at 5 to 6 o'clock. I will start working with the child. Where is the connection? And what observation you have done in 15 minutes? And what parents have told you, not necessarily that is the true thing, because parents are driven with emotions. They will tell you only their concerns, matter of concerns, areas of concerns. Sometimes parents are overstressed. Yes, they are. Their child has been diagnosed with autism. They never heard of autism before. They don't know what it is. And suddenly something like this has come up. They are stressed. Under stress, what input they give you may not be the correct one. And on basis of that input, you are planning next 3 months goals. And then you work with correction. Then you work with, no, this is not working. This is not working. So first 15 days in IDHA process, compulsorily, child has to go for play therapy only with various therapists who are going to get involved for the therapies. And they need to connect with the child. That is one goal. And the second goal is they need to take down their observations, on basis of which they will be creating their goal sheet. Parent should go to all therapists, one session with all therapists, and then counselors to manage their, for initially counselors to manage their stress. By the time counselor work for 7 days is done, less 7 days, parent are going meeting one therapist in 1 day. By this, in 7 days, therapists have seen the child, observed the child, they have their opinion about it. So they don't get influenced with parents' opinion. Idea is that parents' opinion should not influence my observation. If I'm just going to create assessment in just 1 hour, I'm surely going to go with parents' opinion, not with my observation. My observation would become secondary, but parent opinion, parents' observation, parents' input will be the primary thing. So I want to break that. That's why I'm taking 15 days. Then phase 2 is after 15 days, say on 15th day or 16th day we keep. So we, in IDHA, what we are suggesting is every fortnight, 2 meetings, team meetings. So on 15th day and 30th day, we don't do any therapies, only the team meetings and case discussions. It's like a corporate which has a boardroom and they have their own meetings. 1 day, no work, all the sales team, all the marketing team, HR team, everybody comes together, operations team, and they have full day long meetings like that. So 15 day and 17 day, 15 day and 38 days. So after 15 days, we have team alignment. So everybody comes with their own assessment, their own goals. Come and sit together, integrate those goals, connect. This is my observation, this is my observation. So we take the name of the child and we talk about our observations and we create an integrated goal sheet. So team is aligned. What are parents' concern? Parent has told one concern to occupational therapist, which they didn't tell to speech and language therapist. That time they didn't remember this, or something, this question didn't come to them. So what were parents' concern? What are observations? An autist opinion about a child, observation, speech therapist observation, behavior therapist observation are definitely going to be different. Because everybody will think from their own angle. Autism is an elephant and we all are blind about it. So when we see the elephant, feel the elephant for the first time, if I'm touching the tail, I will say it is like a snake. If I'm touching the legs, the speech therapist is touching the legs, will say it is like a trunk. So it is the same. Together, once we do team alignment, we create elephant. We are able to shape that elephant. Okay, elephant is like this because autism, in this child, autism is like this. So phase 3 is single IP design. After this team alignment, we design single IP. And then implementation of this IP across environment. So parents are also involved after IP is designed, they are trained on it, and they need to implement. Their school teachers or special educators are also involved. They need to do it at the school and at home also. And therapists, we have some therapy assistants in IDHA who take the child out in public places and we implement the goals in public places also. Then review and evaluation, phase 5. So once the goals are going on, every quarter we review, we evaluate the goals. Same process happens in that. So this is the complete IDHA process. Along with the principles, the core philosophies. Philosophies we need to keep in mind while doing it, but the process is this. Core tools, which tools we are using in IDHA? Developmental observation metrics. So we are doing the observation of the child, developmental observation, sensory profile and regulation map, functional behavior analysis sheet, single ITP template, and parent counseling guide. Single ITP template is individualized therapy plan. So same like you have IEPs, it's ITP. IDP also we say it IDP, that is individualized development plan, and ITP is individualized therapy plans. So all therapies connected together, therapy plans connected together, and then given roles. It's like somebody is coming at your home for dinner and you need to make 5-course menu. So you plan together. Okay, you are good at soup making, you make soup and snacks. You are good at dessert, bakery, so you are baking the cake today. Or you are good at Mughlai food, you want to make biryani, so you will make biryani. It's like that. But menu is compiled together. If you don't compile together menu, if everybody is making their own things, then definitely the whole food menu will go wrong. Because the combination, the appeal, the textures, they should align with each other. That's how we plan the menu. So if in main course, if I'm giving seafood, and then you are asking to serve something banana milk shake in after the food dessert, which doesn't go with the combination. So need to connect with all the therapists, create single ITP. Once ITP is created, then you share your own areas. Okay, this I will take, this I will take, this I will take. And parent counseling continues side by side. That is important. So these tools allow IDHA to be replicated globally. We have already started this in Mauritius with Angel Special School, and we are seeing wonderful results there as well for IDHA. So IDHA and evidence-based approach integrated, not exclusive. So IDHA integrates which all approaches we are integrating here. Tools we have seen the philosophies, now the approaches which we are integrating. Flow time approach, ABA principles, ethical and functional, sensory integration, primitive reflex integration, yoga and mindfulness, exposure-based social learning, pet therapy, and emerging research. So IDHA does not compete, it integrates with each. IDHA versus traditional autism management. So traditional autism management, we focus on symptom control. Whatever are the concerns, we focus on that. But in IDHA, we focus on functional independence and quality of life. So we work more on the ADLs, activities of daily living, and independency and quality of life. So traditional models often focus on controlling symptoms, stopping behaviors, increasing compliance, chasing milestones. So command following, compliance following, reaching to the milestones, stopping behaviors. But IDHA asks a different question. Is this child becoming more regulated, more confident, and more independent? IDHA works towards that. For example, is the child able to wait calmly? Can the child communicate needs functionally? Is the child participating meaningfully at home, school, and in society? Success in IDHA is not measured only by test scores. It is measured by real life functioning and emotional well-being. So this approach shifts our focus from age to developmental readiness, from correction to connection, from isolated goals to one unified plan, from parent anxiety to parent confidence. So today's session is designed to help you change how you observe, think, and plan for a child with autism, not just what activities you do. So today we are discussing these things purposely because I want you all to change your approach and see the results. Try it yourself. Just change your approach, change how you observe, think, and plan for a child. So from age to go for developmental readiness, from correction go to connection, isolation goes to one unified plan, and from parent anxiety to parent confidence. Support parents for that. Flow, I have already told you. Observation and assessment phase is 15 days. Team review and goal settings then single individualized development plan, IDP is developed, and integrated intervention and reviews are there. IDHA is not a random therapy. It follows clear intentional flow. The first 15 days are not about fixing the child. So first 15 days when you are working with the child, you are not going to give any instructions or try to correct the child. They are about understanding the child. So let the child play in his own way. You try to connect with the child, try to imitate the child so child feels more comfortable with you. Whatever child is doing, you also do that in play. So use flow time approach. We observe, connect, play, and listen, especially to parents. After 15 days, the team meets not to compare reports. Again, teammates are not to compare, okay, you have done this, you have not observed this, you have not observed this, this is there. Oh, you did see this? Child is doing this? No, it is not to compare, but it is to create one standard understanding. From this comes a single individualized plan, IDP, a single individualized development plan, one child, one plan followed by everyone. This flow reduces confusion, increases consistency, and most importantly, makes the child feel safe and understood. So everything we discussed today will follow this flow. If you do not remember any of it, just remember one line. Autism management starts with understanding, not correction. So you need to understand the child, be it adult, be it any human being who's on autism. You just need to understand them. You will automatically get the ideas to manage it. But if you don't understand them, you keep on correcting them, they will not work with you. They will not connect with you. So first 15 days, do not rush into correction. Focus on understanding the child, natural environment observation, and relationship building. Work on that. And no pressure-based correction. So no rushing into correction and no pressure-based correction also. The first 15 days are most often misunderstood at the most important phase of autism management. During this time, we do not try to change the child. Nothing is going to happen in 15 days. Trust me, if child is diagnosed today and we are taking 15 days on time to settle down the child with us and to develop the connection, no worries. We observe how child regulates emotions, responds to sensory input, engages socially, plays, explores and avoids, communicates his needs. Why? Because intervention without understanding creates resistance. Think of these 15 days as listening to the child's nervous system, how child behaves, how child thinks, how child responds, how the cognition is working. When we rush into correction, we may see compliance. Yes, if you rush into correction, you may see that child has started following you, doing the compliance, but we lose trust. So IDHA chooses trust first. Multidisciplinary assessments, we do psychological developmental, by psychologist and developmental specialist, by occupational therapist, speech and language therapist, behavior therapist, special educator, and diet and nutrition screening. All of this we do in IDHA, we should do. In IDHA, assessments are not isolated reports. Each professional observes the child through their own lens, but with a shared goal, to understand the child holistically. The OT looks at regulation and sensory processing. Speech therapist looks at intent and communication readiness. The psychologist looks at emotional processing and behavior patterns. The educator looks at learning style and participation. No one works alone. No one label dominates the child. This prevents conflicting goals and fragmented intervention. Focus area, developmental age, brain and sensory processing, motor and communication skills, emotional regulation, and social engagement. I hope you all are, I'm not just reading it, you all are connecting with it. Any doubts, confusions, you can ask me in between. I'm just trying to give you some ways so that you can change the way you work with your child, with the children with autism. So assessment in IDHA goes beyond checklist and scores. We ask what the child is ready for. We don't ask for what are the concerns in assessment. What overwhelms the child? What calms the child? What brings joy? Developmental age guides expectation. Emotional regulation guides learning capacity. So we create expectations from the child as per the developmental age. A child who is dysregulated cannot learn, no matter how good the program is. So we need to work on regulation of the child. These focus areas help us design human, realistic, and effective goals. First 15 days, we have flow time focus. I've already told you flow time focus is what? Follow the child's lead. You are not instructing the child in flow time. You are following what child wants to do. You give options to the child. Child wants to play, child wants to do painting, child wants to sit and look at something, or child wants to jump. So you just follow child's lead. Build emotional connection with the child. Shared attention and engagement. And no pressure-based demands. No demands from the child. We need to have demand. Okay, let's do this, let's do this. Instead of saying do this, let's do this. But no pressure-based demand. No, you have to do this. Come, sit here. No, no such instructions. If a child wants to go and sit elsewhere, no problem. Let him go and sit. You go and sit with the child. That is our flow time focus. So it's not just a technique, it is an attitude. That attitude should be there in us. All of us should start practicing. That works really good with children with autism because they feel connected with you, be it adults and children both. So flow time, first 15 days we are focusing on flow time, but this attitude should continue with us. Even if you are a parent, you should have the flow time approach. Child will connect with you much deeper. So we follow child's interest, we respect child's space, and we join, not direct. So we join child in what child wants to do. Why is this critical? Because connection builds safety and safety builds learning. A child who feels emotionally seen will naturally engage with you. Flow time helps us understand how the child initiates, responds, and sustains interaction. Information no test can give us. So we don't do any scorings and testings in this, but we work on the flow time, which gives us the true essence of the child, how child feels, how child looks at things. Basically, you understand how child's brain is functioning if you go for flow time. If you're giving instructions, child's brain is not functioning. Child's brain is just responding to you. But how child is looking at things, so you understand what he is liking, what he is not liking. You just observe with that. Observation in first 15 days is important. Play therapy and natural interaction in 15 days. So play is as a primary language, symbolic and functional play, and joyful interaction. So we do play with the child because with their playing style, they communicate to us. So through play, we observe imagination, flexibility, emotional expression, problem solving, and social reciprocity. All these areas we can observe in the child through play. Play therapy is not about toys, it is about relationship. When play is joyful and pressure free, children show us true abilities. So no commands, no pressure, let it be joyful for the child, and then you observe. Then you will be able to get the true abilities of the child. How child is able to imagine, what is the flexibility child has, emotional expressions child has. This information is priceless for planning intervention. So observe during the play therapy. Parent interview and history taking, developmental history we need to take, daily routines we need to check, parent concerns and expectations also we need to take into consideration, and family strength also. So we need to see the family members who all live under the same roof, what is the family dynamic, what are the strengths of this family, we need to look into that. So parents are not observers, parents are expert on their child. The parent interview is not just data collection, it is relationship building with the parent. We are connecting. That's why I'm saying parent interview, therapist should do it after 1 week of play with the child, because in 1 week you know the child and then you are going with parent. So you both connect at the same level because you're talking about the same child. We listen without judgment, we validate experience, we acknowledge exhaustion and fear. This step builds trust, which is essential for long-term success. A parent who feels heard becomes strong therapy partner. So make parents your therapy partners. Parallelly, first 15 days with child we are doing all this. Parallelly, we are working on parent education with parent. So understanding autism, developmental perspective, removing guilt and blame and all those social stigma and stresses, and building realistic expectations. These should be our goals with parent in first 15 days. So we gently correct myths, what they have in their mind, we remove the blame, we explain autism as a neurodevelopmental difference, not as a failure or not as a disease or concern or not bad parenting. When parents understand development, their anxiety reduces. Calm parents create calm environments and calm environment supports learning. So automatically child gets into learning phase. Parent acceptance process. Now acceptance is not one-time goal, one-time thing. Usually we feel that, okay, we have worked on acceptance, parent is ready to accept, parent is accepting, okay, child is with autism, no problem, I have to do all this. Acceptance is a continuous process for parents. They need to accept their child at each stage, every day. Every moment, every single next moment they get frustrated, they need to accept. So acceptance is a continuous process which we need to create, which support system for which we need to create. So emotional validation, normalizing feelings from denial to understanding and from fear to hope. That is the process of acceptance we need to start with in first 15 days. So acceptance is a process, not a moment. Parents move through shock, denial, guilt, fear, grief. All of this parent go through. IDHA does not rush this process. We support it. When parents accept not the diagnosis, but the child as they are. I accept child is with autism, but I accept the child the way child is. These are two different statements. I accept the diagnosis. Yes, my child is with autism. I accept. Initially, they are in denial. Denial of diagnosis also. They want to go to other specialists and want to go for confirmation. But later on, they want to, just one moment. Okay. So later on, they want to accept it. Okay, diagnosis is there, but they don't accept the child. So we need to teach them, we need to support them in the acceptance process. So intervention becomes consistent and compassionate once parents accept their child. And then once the acceptance is there, we need to start building parents' future vision also. So short-term functional goals, long-term independence planning, education and vocational outlook, all of this we need to support parents with. Parents often fear the future because they cannot imagine it. So the major worry of parent is when they come to us, will he be able to study? Will he be able to do job? Will he have his career? Will he get married? Who will take care of him after me? What if something happens to me? Then who will take care? All of these are parents worry future because they can't imagine it. For children with neurotypical development, parents imagine. Parents imagine that I want my child to go to US for studies, or I want my child to go to Pune University for studies, like that. or I want my child to become a doctor or become an engineer. I want him to get married to a known family. All those things we imagine. But children with autism, they are not able to imagine it because of the concerns. So we need to help them build a clear, realistic vision. Not will my child be normal, but how can my child live independently and meaningfully? Vision gives hopes and hope fuels consistency. So parent counseling and confidence building. So I have some chat messages. Let me just look at them.
Doctor, I have a question.
Yeah, please.
The question is, as I've already mentioned, that one of our, I would say my grandchild is autistic. My sister's grandchild, my grandchild as well. So he is very keen on when even when he's going for class, food is the only thing where they can manage with. So that is the only what to say appreciation or whatever it is. Only through food they do it because he's so inclined towards food. So anywhere anything kept, he can identify. He goes and he takes. In his absence, something kept. Also, once he comes back, he knows where it is. Something is there. He knows. He goes and finds for it and he takes it. So, do we understand that his thinking skills are not there, or how do we take this as? Because just now it was told that their thinking capacity is very less when compared to us.
No, I'm not saying thinking capacity is less. We need to look at their cognition, how cognition is working.
Okay.
Processing, how brain is processing information. When we observe, we understand, okay, this child is processing this information this way. It's like if you are doing something in some activities, if I come and stay with you and if I keep looking at you, keep observing, I understand how you like to do things. So how your brain is processing. You like to keep your clothes clean or tidy. You want to keep them managed, well managed. You want to keep things in their own places. So looking at your daily routine, I understand, okay, I create a framework in my mind that, okay, Mrs. Sudha is like this. The personality is like this. Similarly, how she thinks. This is how we know that for our relatives, for our friends, when we talk, we say, no, no, don't tell him this way. He will feel bad about it. He will not accept it. Why? Because we know the way they think. So we need to observe our children. I'm not saying they think less. No. Many of them, they think a lot also. Their imagination is very high. So we need to observe how their brain processes. Accordingly, we can plan our intervention. When we are planning intervention, if we know how the brain processes for this child, we plan things that way so that child does not get disturbed, child feels comfortable, child enjoys it. It's like taste buds. You know your family members' taste buds. So you know somebody who in your family who does not like much of chilies or spicy food, and there is someone who likes spicy food. So if the first one who does not like spicy and coming over for dinner, you make food that is less spicy. For the second one who is coming home for dinner, you will make food that is more spicy. You will select menu accordingly. You will select items accordingly, right? Similarly, if I know how the cognition of this child is working, I select my intervention accordingly. That's why I want to give time to observe this child. Instead of starting with therapies immediately, instead of starting the instruction-based program, I want to observe for first 15 days and create my own, notes how child's brain is processing.
Thank you. Thank you, Doctor.
So cognition processing can be much faster also. Many children with autism are blessed with extra talent like numbers. Many of them, they can do calculations very fast, multiplication and all those things very fast. So we have in autism, there are many children. Autism is not slow learning or slow brain processing. No, autism cognition could be very fast also, very slow also, different. It is just different. Okay, so Neeraj Goyal, okay, somebody has said that how we can enroll into it now. No, you don't have to enroll. What I am saying today, I'm giving you the summary of this program, this research of IDHA. You can start implementing in your daily life, in your practice. Yes, we are going to come up with a detailed training program where we'll be talking like, whatever I'm talking today, each part will be elaborated and then hands-on practice would be there. We'll give you the formats and all that will come up later. But today's session is not to market training program that you have to enroll in it. Today's session is about giving you the IDA, like basic IDA guidelines. So you can start using them within your practice. That will help you. That is what is my motto today. That if you start using not all of it, even whatever you can adopt easily, start adopting that. That will help. Neeraj Goyal says important points, but due to school, okay. No problem, Neeraj. Thank you. Thank you. Okay. So parent counseling and confidence building, strengthening coping skills, reducing anxiety, empowering decision making, and parents as partners. So let us consider parents as therapy partners for us. Confident parents raise confident children. Parent counseling is not optional, it is foundational. We empower parents to trust their instincts, understand behavior, and respond calmly. When parents feel capable, therapy continues beyond clinic hours, and that is where the real change happens. Real change does not happen in the therapy, in the clinic. In clinic, we are just tasting it. But real food we are eating at home, in our other environments. So clinic is just for tasting, but practicing has to be done in other environments. So that's why parent cleaning is there. The first 15 days decide the next 15 years. The connection you build with the child, and we have I mean, like many of the children whom we started seeing when the child was 3 years, 4 years, and still now they have become adults now. They are pursuing their career, and till now we are connected with them. Many of them are like this. Me and Dr. Kanan Doshi also, we are working together for so many years, and we have those children. So the connection what you develop with the child in first 15 days, connection what you develop with the parent in first 15 days, then there are no if and buts from parents also. Once you have counseled them for 15 days, you have connected with them, you have shared the vision, they have become therapy partner with you, then you don't have to worry that they will go to some other professional, they will leave you, they will go jump. This window shopping of therapists, what happens after 3 months we are here, and 3 months after fourth month they see no development is coming, okay, we are going to some other therapist. That will never happen. So competition concerns will go off. So when we begin with understanding, connection, and parent confidence, everything else becomes possible. Now, first 15 days phase has passed. After 15 days, what we are going to do is team meeting. So share assignment findings, understand child holistically, discuss strengths and challenges. After first 15 days, we do not sit with separate reports. We sit with shared understanding. This team meeting is not about whose assessment is correct, and it is about who the child is. So in team meeting, we don't get into that competition, this is correct or this is wrong. We give weightage to each person's input and then create a figure with us that who the child is. Okay, this child is this his processing works like this, his expectation, his strengths are these, he enjoys these activities. All of this we compile in this team meeting. So each professional shares observations, what helps the child to regulate, what overwhelms the child, what motivates the child, and how the child connects. Basically, in this also, what I'm not trying to find out what are the weaknesses of the child, what are the core concern areas. No, I'm just trying to find out strength-based assessment. I'm trying to read child's uniqueness. I'm trying to read the way child behaves, child's behavior. So when professionals listen to each other, contradictions disappear. This meeting shifts us from my therapy to our child. So the purpose of team meeting is prevent fragmented information, build common language, and respect each discipline. One of the biggest problem in autism management is conflicting advice. Some of you, I think Ujra said this also, that different professionals have different advices. Yes. So one therapist says, ignore this behavior. No problem, you can ignore this. Another says, prompt immediately. Oh, this behavior, you need to focus immediately, you need to start working on it. Parents get confused and children suffer. Parent confusion is still okay, acceptable, but children suffer. So the team meeting creates a common language. We respect each discipline, but we align goals. When professionals are united, parents feel safe and confident. So designing common goals, unified developmental goals, functional priorities, and emotion and regulation first. So after this, when we do the team meeting, we understand the child, we come on a conclusion, okay, child is this, parent is this. Now we need to design common goals. Then we find out developmental goals from each of the domain and unify them. Then find out the functional priorities for the child. What are the functional priorities as per the developmental age? And then emotion and regulation. First of all, we start working with emotions and regulation. So goals in IDHA are not discipline based, they are developmental based. We ask, does the goal support regulation? Does it improve daily functioning? Is the child emotionally ready? So we don't go as per the routine disciplines. Okay, gross motors, we need to work on these areas. Fine motors, we need to work on these areas. Speech, we need to start with this. No, we go for, we create the goals and we work because functional goals. Is this goal supporting the child in regulation? Does it improve daily functioning, helping the child in daily functioning? Or is the child emotionally ready for this? For example, we do not change academics when a child cannot sit calmly. Common goal ensure that OT, speech, behavior, and education, they all go together. All are working in the same direction. Then we develop the single individualized developmental plan, IDP. One child, one plan, integrated across domains, and avoid fragmented goals. This slide represents the soul of IDHA. The soul of IDHA is IDP. What you call IP in other therapies or education, we are calling it IDP here. Individualized development plan. So a single IDP means one vision, one set priorities, one developmental pathway. This plan belongs to the child, not to any one therapist. So this is child's plan. This is not my plan, my plan, my plan. This is child's plan. We all are part of it. We all are working for it. When intervention is unified, learning becomes predictable and safe. And what is single, not IDP? It should be IDP only. Single IDP includes, I'll correct it, strengths and interests, challenges and support, developmental goals, and environmental based strategies. So we work with strength and interest, challenges, and what support we can provide for that, developmental goals, and environment based strategies. A good ITP includes, ITP begins with strength, not deficits. Okay, this has to be IDP here, not ITP. I think I did a mistake while typing. I will correct it. So good ITP begins with strength, not deficits. We identify what the child enjoys, what motivates engagement, what causes distress. Goals are written in functional language, not reduce stimming, but increase calm participation. So when calm participation is increased, automatically that means stimming is reduced. But we focus on increasing calm participation rather than reducing stimming. Concern is stimming, but stimming automatically disappears when calm participation increases. So we work for the calm participation. It also specifies how strategies differ at home, school, clinic, and public places. So in the IDP, we have different strategies for different environments: school, home, clinic, and public places. So in clinic, we'll be using these strategies. Home different, school different. Goals are same, but strategies are different. IDP followed by everyone: therapists, parents, teachers, and caregivers. All of us follow our IDP. So we all are part of it. We all have roles to play in it. An IDP says in a file is an IDP that stays in a file is useless. If you just create IDP and put it in the file, it is useless. So in IDHA, everyone follows the same plan. This does not mean everyone does the same activity. When I'm saying following the same plan, we have our own roles in that. It's like a movie, play, stage play, where you have your own character to play, other person has own character to play. So it is not that the same activity list of activities will be given and everybody is doing it. It will be, child will become monotonous, child will feel so monotonous. It means everyone supports the same developmental goal. My goals are same. Activities are different. The activities which I can do in a clinical setup and activities I can do in a public setup or at home are different. They have to be environment friendly. They have to be related to the environment. So consistency across environments builds faster learning, reduce anxiety, and better generalization. So if we have the consistency of the same developmental goals in different environments, environment again consists of three things: people, physical settings, and different materials. So it helps in faster learning, reduced anxiety, and better generalization. So why single IDP matters? It is for the consistency, it is for the faster progress, it is for reduced confusion and better generalization. Children with autism struggle with unpredictability. When expectations change across settings, anxiety increases. And expectations change as per child's behavior at home and child should behave the way child should behave at a clinic. Expectations are different. So anxiety in child increases. A single IDP gives the child predictability, safety, and trust. And it gives parents clarity. Progress becomes smoother, not because therapy hours increase, but because confusion decreases. So at home, when we are providing in IDP, when what we are doing is we are not asking parent to sit and give therapy. We are including our goals in the daily routines of the child. So therapy hours do not increase, but confusion decreases. Child learns in different environment with different people. Then comes, once it has started, regular review, development-based updates and family feedback. That every quarterly we are suggesting it is must. That regular review, every quarter we need to update our IDPs and plan for the next quarter. So IDP is a living document. It is not just a paper, it's a living document where you keep on putting your inputs, new entries, and as the child develops, goals also evolve. Parents' observation are critical here. So IDHA respects that development is dynamic and planning must be flexible. So whatever I'm planning, no matter if the child is not able to support, if the child is not going as per the IDP, I'm not rigid in this IDP that no, we have to do this only. I can review it. I'm saying to review it after a quarter, but if parents' observations are there and parent is complaining or finding that we are not able to bring any changes, subsequent development, then we may have to review it even after a month also. So we need to be flexible about this planning. When professional works in silos, children adapt to systems. So when professional works separately, then also children adapt system. It is not that children do not adapt system or children do not learn. But when professionals work together, systems adapt to children. And we want the system to adapt to children. Some of the core principles. Now you have understood, everyone. First 15 days phase, then team meetings, and then planning the IDPs and review after a quarter. And using it across environment, involving parent, involving teacher or special educators. In every environment we are using it with different people and different materials. Clear? Okay. Thank you, Captain Bhavna. Now, I think there is a chat message. Let me just read that. Yes, sir. Okay, Kapila. Thank you. Now, some of the principles which we are using, I've already told you about these principles, but I just want to explain them. Developmental age versus chronological age. So chronological age is calendar age as per year of birth. So as per year of birth, child is 5 years. Child was born in 2020, now 2025, child is 5 years. That is chronological age. But as per development, child may be at 3 years, child may be at 4 years or 2 years or 1 year. So we need to go as per developmental age. Development drives learning. Age levels limit progress. So we don't have to go as per age level. That is one principle. Brain processing in autism. So in autism, sensory differences are there in each child. We need to look for that, and we need to make sure that information overload is not there. So too much of information, too much of therapies is also dangerous for the child. So we need to look for these. Bottom up development. Yes.
Sir, I have a doubt.
Yeah, please, Anand.
In the previous slide that we want to work on the developmental age of the child, right, sir? So according to you, what is the in which milestone is the development, sir? Is it a cognitive milestone or a social and emotional milestone?
All of them together.
Okay.
That's why we are, giving this approach, that we need to see all areas and see the developmental age as per all. And developmental age might be different for each area domain also. For
Yes,
speech
sir.
and language, age might be different. Communication age might be different, and cognition age might be different also. So as per child's development, you don't have to calculate. For rough understanding, I'm saying child might be at 3 years age or 4 years age as per developmental age. You don't have to calculate developmental age. You just have to see where does the child stands in speech and language and teach him the next. Instead of relating it to the age that child should stand here and child is standing here and then I'm trying to pull. Anand, it's just a thought process is different. Nothing is going to change in therapy. Therapy you are going to provide in the same way. But I'm trying to play with your thought process as a professional or as a parent, both. In one process, I am checking the child is at level, say at level on 0 to 10 scale, child is at level 3. And as per 6 years, because child is 6 years chronological age, as per 6 years, child should be at level 7. So what I'm trying is, I'm saying 3 to 7, oh, this much gap is there, I need to pull child fast. Otherwise, next year, child will become 7 years. At 7 years, child should be at the level of 8. So time is running. So I'm in hurry to pull the child. That is the current scenario. But what I am saying is, just see, forget about the chronological age, just see where child stands. Child stands at 3. I need to reach at 10, I know that. No matter child takes 1 year to reach at 4 or 2 years to reach at 5, don't push, don't pull the child too harsh, just go step by step. And here you will see development is faster because the stress part of parents, stress part of therapist is gone. Major stress. Now when I give you time, okay, you have your own phase to study, you study as per your, or otherwise I give you a stress that tomorrow we need to submit this. There is a difference. Time is running. If you don't submit it tomorrow, you'll be like behind. Otherwise, okay, you have time for 1 week. As per 1 week, you take your own time and submit. Your submission would be more effective, more impactful if you are given some sufficient time. And many of you will submit well in advance also. You're with me, Anand?
Yes, sir. Yes, sir. I'm listening. Yeah.
Okay.
Thank you, sir.
So bottom up development. Bottom up development is regulation, engagement, and learning. We don't start with learning. We first work with regulation, then engagement with the child, and then go for learning. In traditional method, what we are doing is we are starting with learning. What I'm teaching to the child. Child should learn this. Child should learn this. Engagement and regulation I'm developing side by side. But here is bottom up development. So first regulation, then engagement, then learning. Motor development, gross and fine motor foundations we need to work on, yes. Sensory integration, regulation before instruction, yes. Primitive reflexes, impact on posture and learning, that also we need to look into. Emotional development, safety and trust first. That's what I'm trying to do in first 15 days, win the trust of the child. Create a safe environment. Let the child be comfortable with my environment. Then motivation and interest, engagement through strength. So in IDHA, I'm always, right from beginning, I'm talking about strength, and I am engaging child through the strength part. The challenges I'm working on, but with the help of strength, I'm working on the challenges. So child stays motivated and his interests are taken care. Behavior as a communication. So we understand functional understanding. We understand child's behavior. First 15 days I'm spending with the child to understand the way child behaves and what he's trying to communicate to me with his behavior. Then flow time integration, I've already told you, relationship based learning, flow time, you connect with the child. Communication development, yes, that is another area we need to work on with the child, with functional and social communication. So we work on functional communication and social communication first. Social development through exposure. So real life experiences we give to the child. When I take the child to public places and do therapies there, when I take the child to different environment, so child learns from exposure also. So in IDHA plan, I'm giving exposure also to the child. Child is not just home to therapy and therapy center to home. I'm taking child to the public places. I'm taking him to the bus stop, railway station, to zoo, to the garden, and child is learning through social, real life experiences. Therapy all across environments: clinic, home, school, and public. These are the four major environments child usually goes to. So therapy beyond clinic. So beyond clinic therapy gives real life skill development, generalization of learning, context-based therapy. So many a times we see that child has learned things, but child is not able to use it effectively when it comes into different environments. So at clinic, child is able to display things, or at home in front of parent, child is able to do it. But when it comes to going in a public place and do it, child is not able to do it. So generalization part is missing. So when we provide therapy beyond clinic, we add real life skill development, context-based therapy, and generalization of learning. So one of the biggest limitations of traditional therapy is that it stays inside four walls. A child may perform well in the clinic but struggle at home, school, or public places. So IDHA believes if a skill cannot be used in real life, it is incomplete. No point in learning that skill. So we need to complete it. So every skill we teach to the child, we implement it. We take the child into, purposely we take the child into an environment where that particular skill has to be used. Suppose child has learned counting. Then I take the child to public place, to the garden, and ask the child to count. I create that environment that child has to count there, not through instruction, but in the life. The child has to count. Therapy must prepare the child for the world, not protect them from it. That's why therapy beyond the clinic is involved. Therapy at home is natural routines, parent-led strategies, and emotional safety. So when we provide therapy at home, we don't provide therapy as in parent has to sit for 2 hours and give this therapy. No, that is our job at clinic or at public places. We are doing it through our support staff. But at home, we are building our goals. We are integrating those goals within the natural routines of the child. And parent-led strategies, not the clinical strategies. So strategies we are giving them which parents can lead easily, comfortably at home environment itself. And it also provides emotional safety to the child. So home is the child's emotional base. Here we work on daily routines, emotional regulation, communication of needs, and activities of daily living. Parents become co-therapists, not professionals, but confident guides. When parents are empowered, therapy becomes continuous, not limited to sessions. Then therapy at school. So in school, classroom participation, peer interaction, learning readiness, all of this we develop in the school. School is not just about academics. Yes, it is true. It's not just about academics. In school, we learn social things, a lot of social activities. So it's about following group routines, setting tolerance, social boundaries, asking for help. IDHA works closely with teachers to modify expectations, not to lower them. Support is based on developmental readiness, not age norms. Therapy at public places, exposure-based learning. So we give exposure to the child, on basis of that child learns. Managing unpredictability, also child learns there. And social tolerance, also child learns in public places. So public places challenge every sensory and emotional system. Malls, parks, temple, hospital, these environments teach flexibility and resilience. IDHA uses graded exposure, not forced compliance. So we give exposure slowly and we don't force compliance to be done there. So first we'll take the child to a place, in public place, where very less people, very less sensory input and very less challenges are there. Let the child be comfortable with that, then we'll take the child. So in our therapy goals plan itself, we keep at least 1 day public therapy every week, public place therapy. So we prepare the child, support regulation and gradually increase demand. Avoidance builds fear, exposure builds confidence. More the exposure they get more confident. Generalization of the skills. Now, same skill, whatever we are teaching to the child, we are teaching in different settings for flexible response and functional independence. So generalization does not happen automatically. A child who can greet one therapist may not greet another one. So IDHA plans generalization intentionally. Different people, different environment and different material. So if one therapist is giving training, then the second therapist will give, another therapist will give the same training. So different people involved in the therapy at home, parents, sometimes mother, sometimes father. It's okay that my mother has to serve me food, but it's okay that father can also serve the food. That's what we want to teach to the child. So that when mother is not there, suddenly if she has gone out for some work, father can serve the food and child should eat it. Father can feed him. Otherwise, they become very rigid. They want specific tasks to be done by specific people only. So real independence comes from flexibility, not memorization. So generalization of skills is very important. Motivation, emotion, and strength-based intervention. So whatever intervention, all of this we are using, but whatever interventions we are using, we are doing them motivation, emotion, and strength-based. Again, ADLs, activities of daily living and independence, we are focusing on. Life skills, we have the focus. Motivation as the engine. So we have intrinsic motivation, interest-based learning, and emotional engagement. So we keep child motivated. We create such environments where child is motivated to do a task. Instead of instruction that do this, child should be motivated. For an example, intrinsic motivation. Child loves to play with teddy bear. Every day child comes to my clinic and takes that teddy bear. Today, purposely, I keep that teddy bear a little height of the child, heighter than the child on a shelf, and keep a small 1 to 3 steps there. You know the wooden step 1 to 3 we have. So child demands that toy. I motivate the child to go and pick it up. Child steps, climbs on 1, 2, 3, picks it up. The child, that's called intrinsic motivation, that from inside child is motivated because child wants that toy. So he is motivated to climb up steps. Like this we create environment. So motivation we keep as the engine which pulls the child to learn, interest-based learning and emotional engagement of the child. So learning does not happen through pressure, it happens through motivation. IDHA identifies what the child enjoys. Music, movement, objects, sensory input. Motivation is not bribery. It is respect for how the brain learns. When motivation is present, attention follows. Automatically, child follows the attention when motivation is there. Then emotion. Emotion drives behavior. Our behavior is directly linked to our emotions. If I am in happy mood, joy mood, my emotion is different. If I am in the emotional stage of sadness, my behavior is different. Though I know the skill, I know communication, but my communication also becomes different and different. If I'm angry, if I'm in anger emotion, my behavior is different. That happens with the children also. So emotional regulation first, behavior as communication. Respond, do not react. Difference between respond and react, can anybody tell me with an example? Anyone? About behavior, we need to respond to the behavior. You can type also, or you can unmute and speak as well.
Okay, respond will be after giving a thought and then accordingly. And reaction is prompt when we don't think and just react with our whatever emotions are coming.
Yes, exactly. Exactly. You are absolutely right. Respond is that you observe what is happening, what child is trying to communicate, and responding to that communication. Reaction is you are responding to behavior, not to communication. That is react.
Yes. Okay.
You are right. So respond is you are responding to the communication. React is you are reacting to a behavior. So once we understand, once we observe communication behind behavior, we respond. But if we just see the behavior, we react. Just a moment. Yeah. Okay. So behavior is the surface, emotion is the source. IDHA does not ask how do we stop this behavior. We ask what is the child feeling and how do we help to regulate it. A regulated child does not need control, they need understanding. So strength-based approach now, motivation, emotion, and strength-based approach. So what is strength-based approach? Identify abilities, build confidence, use strength to address challenges. So I catch hold of strength and address challenges. If my child's strength is with numbers, so I teach things to my child with numbers. I teach social communication also with numbers. So I first identify the abilities, the strength child is good at, and then practice the same that gives them confidence. And use strength to address challenge. Every child has strength, even if they are hidden. IDHA uses strength as bridges to development. When children experience success, confidence automatically grows. So we start from the level child is. We don't start from one level above. So child is at level 3. First 3 days, I will do things which are of level 3. Child has already connected with me in first 15 days. Now I have created IDP. After IDP, I'm talking about strength-based approach. So I will do purposely, for 3 days, I will do activities with the child, which child already knows and does at home. Parents should not misunderstand this, why this therapist is doing the same thing for 3 days, just playing with the ball with the child. Child can play with the ball at home also. He's not teaching anything. All these concerns we address pre-hand in our 15 days consultation counseling to the parent. But the approach is first you start from where the child stands, spend some time with the child there, child connects with you, child gets confident in that. When children experience success, if child is able to catch a ball, and we know that he can catch, so if I play with him for three days like that, he's catching it, he has that confidence. Now child is confident in catching a ball. There I start with the next step. So confidence reduces anxiety, reduced anxiety improves learning. This is how strength based becomes tool, not labels. So after motivation, emotion, when strength based intervention, it comes connection and confidence building. We have started with connection and confidence building. So connect before correction, trust based intervention, emotional safety, and relationship first approach. Correction without connection creates resistance. If I try to correct you without any correction, immediately there is a resistance which will come from you. And you will say, no, I'm doing right. I'm doing it for this purpose. You'll try to justify. Even if you are wrong, you'll try to justify. But if I have connection with you and then correct you, you will listen to me. So correction without connection creates resistance. Connection without correction creates stagnation. So IDHA balances both. Starting always with connection. When children feel safe, they allow guidance. Once they feel comfortable with you, they enjoy you being guiding them to them. They enjoy learning from you. Building confidence in the child, small achievable goal. As I said, the goals which child already know, start from there. Keep small goals, achievable goals which child can achieve. So confidence will come. Then positive reinforcement and emotional validation. So with these strategies of positive reinforcement and emotional validation, so with appreciation, verbal praise, giving them a small candy, so we keep on reinforcing them like this to build their confidence. And emotional validation. Yes, I understand it is difficult for you. I understand. I agree. But let us do it together. I'm helping you. Let me hold your hand and throw it. Throw. See, you could do it. Very good. Clap. Give a small candy. This is emotional validation. So when child has fear, when child is less confident, give him emotional validation. Confidence is built through success, not comparison. See, the other child is able to do, why you are not doing it? You can do it. No, confidence will not come. It is through success. Let the child achieve. Give the less difficult task. Let the child do it. Confidence will automatically come. IDHA breaks goals into achievable steps. So whatever our goals are, we break them into small achievable steps. Every small success tells the child, I can do it. That belief changes everything. So if child is able to do small thing, child feels I can do it, child will do big thing also. This belief changes everything in the child. When planning environment, emotion, and motivation align, development accelerate naturally. So when we plan environment, emotion, motivation, all this planning, environment, or different environments, emotions, motivation, all align together, development comes naturally. We don't have to work much on development, it comes. Then we also use ABA principles within IDHA, human and developmental principles. So ethical, flexible, and child-centered. I'm not going into ABA, applied behavior analysis, into detail, but what I'm suggesting here is the principles of ABA, which I have picked up from there. As I told you in the beginning, IDHA is not something new. IDHA is combination of existing principle, existing concepts in order to promote development in the child in a smoother way. So I have picked up ethical, flexible, and child-centered, the three principles from ABA into IDHA. So ABA we use as a framework, not as force. Functional and ethical use integrated with development. IDHA does not reject ABA. It refines and humanizes it. Because there is a different opinion about ABA, that it makes children robotic. It was developed not for children but for the pets, training the animals. All of these are pro-ABA concerns. So in IDHA, what we do is we refine it and humanize ABA. So ABA is the science of learning, but learning does not happen in isolation from emotion, regulation, and connection. In IDHA, ABA principles are used after regulation, after connection, and with respect for developmental readiness. Compliance is not our goal. In ABA, compliance is the goal. But in here, compliance is not our goal. Functional independence is our goal. That's why I'm saying we have refined it. We used refined principles of ABA. Then comes functional behavior assessment. So we also use behavior assessment, functional behavior assessment for the child's behavior to understand. So behavior has a meaning. We identify the function of behavior, replace it, not suppress it. You all know about it, functional behavior assessment, or you want me to explain? FBA? No?
Sir, we need explanation, sir.
Sir,
Sorry?
please explain it.
Explain. Yeah.
So, functional behavior assessment says every behavior has a purpose. Without a purpose, I will not do any behavior. And those purposes I can divide into, majorly with children, I can divide into 4. Formula is EATS, EATS, I call it as. So I do a behavior either for E or A or T or S. What is E? What is A? E is escape. I want to escape from something, I do a behavior. A is attention. I want your attention, I am doing this behavior. T is tangible. I want some activity or some game or some toy, I want chocolate, food, I do behavior. And S is I have some sensory need, I do behavior. So in behavioral communication, we say that every behavior is communicating something. What it is communicating? That what purpose, for what purpose I am doing this behavior? What is the purpose? It could be either escape, attention, tangible, or sensory. Escape is child finds mathematics worksheet difficult, child runs away. Child finds somebody who is scolding him, child runs away. You are force feeding the child runs away. Or child throws the plate, or child starts hitting you. So this time, hitting behavior is for, what is the purpose? Escape. Again, you are continuously on phone call. Child wants your attention. Child comes to you and starts pinching you or hitting you. This time, hitting behavior is for attention. Then comes, child is super hungry and you are still cooking the food. Child comes to you and starts pinching you or hitting you. This time, hitting behavior is for tangible. Child wants an item or activity. Or child wants to go out to play and you are not taking out to play. Child starts screaming. So screaming behavior is for escape. Is for tangible. And fourth is sensory. Child has some sensory regulation need and child is doing this behavior. Stimming behavior is majorly because of sensory behavior, sensory purpose. So in autism, we classify behavior, we can divide purpose of the behavior into 4 EATS. Escape, attention, tangible, or this sensory. Now, if I want to change the behavior, I don't suppress. First, I understand what is the purpose. I teach the child to communicate that purpose in different settings. So in my therapy goals, I include that I need to teach escape purpose. What could be the escape purpose? How can I teach? Child should know, excuse me. Child should be able to raise hand. If child is non-verbal, I can give a visual card which child can show me, I want break. So this card child shows, I give the break to the child. So child doesn't have to escape. Or child should learn to say no. So food, I don't want to eat, say no, I don't want. So we need to teach the child how to say no. So it serves the same purpose. For hitting behavior, child was communicating to you by hitting behavior that I don't want any more food. But at the same time, when I teach the replacement skill to the child, this is called replacement skill, to say no. So when child learns to say no, child stops hitting behavior and starts saying no. Provided I ignore that hitting behavior, once I teach the replacement skill, I start ignoring hitting behavior and I start promoting saying no behavior. So I give a positive reinforcement to the child when the child says no. When child attempts to say no instead of hitting for food, I reinforce the child positively. Oh, very good. Okay, no, you don't want. Okay, and I immediately address to that. I agree. I go in affirmation with the child. Whatever child wants, I allow him to do for some time. So that child learns that this technique of hitting is not working because you are ignoring it, and this technique is working, saying no. Child makes it, consistency comes, child starts saying no, you start using no in different settings. That is called FBA. And the purpose, functional behavior assessment. So what is the function? Purpose is function in technical term in our language. So we say what is the function of the behavior. So every behavior, when I work on the behavior, I find out what is the function of this behavior and Accordingly, what are the replacement skills for this function? I teach those replacement skills to the child. Clear? Okay. So every behavior serves a purpose. IDHA never labels behavior as bad. We identify, is the child avoiding, seeking attention, sensory regulation, or communicating a need? Avoiding is escape, attention is attention, sensory is S, and communicating a need is tangible. So EATS, easy to remember, eats. Once we understand the function, we teach appropriate replacement behavior to the child. Behavior changes naturally when needs are met. Then reinforcement in IDHA. Natural reinforcement, motivation based, and fade external rewards. So we start giving reinforcement as in some items, some appreciation, positive reinforcement, where we give chocolates, candies, chips, or anything, toys, anything that child loves. Each child may have different likings for reinforcement, so we use them as reinforcement. But in IDHA, we condemn using those things. We focus on natural reinforcement. We focus on appreciation. We focus on giving them stars. We focus on giving them, good words, appreciating them in front of others. We focus on tapping on their back. Very good. Good job. Or we reinforce them by giving some extra playtime, 5 minutes. Okay, you have done this. Very good. Now you can go and jump on trampoline. A child who loves to jump, go and jump on trampoline for 5 minutes because you have done this. I'm giving you this. So we focus on giving in IDHA, we promote giving natural reinforcement and fade external rewards. If parents have trained the child on external rewards, for every time for doing something, child is asking for chocolate or child is expecting external things, we fade that in IDHA. And it is motivation based. More than reinforcement, we motivate the child. So motivation based reinforcement. I have already given you example for motivation, like climbing up the steps. So there I am not reinforcing the child, I am motivating the child to climb up and pick up the toy. Pick up the toy is his need. He wants to pick up the toy. So I'm creating, purposely I'm keeping the toy up. Every day toy used to be down. I'm purposely keeping toy up today, so that because child comes to my center, picks up the toys every day and plays with it. So let him go up, or let him climb up 3 stairs and then pick up the toy. So climbing activity, child is learning how to climb stairs. Next time I may keep it at 4, 5. So slowly child will be able to climb all the stairs also. So in IDHA, reinforcement, we fade external rewards, we work on natural reinforcement. Our strategies are motivation based strategies. So reinforcement in IDHA is respectful. We use social praise, natural outcomes, and instinct motivation. Tangible rewards are temporary tools, not lifelong dependence. So tangible rewards are chocolates, candies, and all those items. So we don't promote them. They are temporary. They are not lifelong. You cannot give tangible in all environments. You cannot carry chocolate everywhere or ice cream everywhere to give to the child. Also, you cannot keep on giving it for rest of the life. So child, it's not lifelong dependency that we can create. The goal is internal motivation, not reward chasing. Child should not be doing things only for the reward, but child should be internally motivated to do the task. Then comes yoga and mindfulness for autism. We had a session also for yoga and autism. So why yoga and autism management? It helps in nervous system regulation. It also helps in body awareness and emotional balance. So yoga is not exercise, it is regulation. You may name it anything, but it is regulation of your body, your nervous system, your emotion. So it works on you physically also and mentally also. So for your brain also, it is a regulation thing, emotional regulation, and it also helps you in your body regulation, flexibility and regulation. So nervous system also it works with. Children with autism often live in a state of neurological imbalance. They are into hyperarousal, poor body awareness, or emotional dysregulation. Yoga helps the brain feel safe inside the body. A regulated body creates a regulated mind. So we include yoga in our autism intervention in IDHA. Mindfulness for children with autism is present moment awareness, emotional regulation, and stress reduction. So mindfulness teaches children to pause, breathe, and feel. So we teach them to pause before reacting. They want to communicate. Sometimes their behavior, they know the skill, they know how to communicate, but they go for their behavior communication because that is easy. That doesn't need much of efforts. So we teach them to take a pause, breathe, and feel. So their brain gets time to process what I'm supposed to do next. Basically, with mindfulness, what I'm trying to do is I'm trying to give time to the brain to react. Same way, it's like I can say, I want child to respond, not to react. So we simply simplify it. Not much of big things in mindfulness, simply breathing games, body scanning, sensory grounding. Mindfulness is adapted, not imposed. Even a few minutes daily can transform emotional stability. Just a few minutes. So every evening at Spandan also, children sit and do breathing, chanting. Every evening after walk, they come back, they take nowadays they are taking soup because of cold weather. So they take soup and after that they sit for 15-20 minutes. They sit for their mindfulness session. So we give them some music, they listen to the music, they breathe, deep breathing exercise, and they uh, do some sensory activity there, sensory grounding. Just lie down on the floor, just turn your body. That's it. Don't have to do much in that. Or even walk barefoot. That also gives you mindfulness. So these are not big things that I'm telling you. These are small things which we have included in IDHA. Brain processing and neurodevelopment. So we understand brain processing differences through sensory modulation, information processing, and response generation. Autism is not a behavior disorder. Please understand. Behavioral disorders are different. It is brain processing difference. Behavioral concerns are visible in autism, but not because of behavioral disorder, but because of brain processing. So a brain may process too much, process too little, process too slowly, or process too fast also. So the answer of your query here, thinking, you were saying that thinking is slow. No, it may process too much of information it may process at same time, or process very less information, process too slowly or process too fast also. So IDHA adapts the environment to the brain, not the brain to unrealistic expectations. Meena, you want to say something? Meena Kumar?
No, sir.
Okay.
No, sir.
So regulation before cognition. So for the brain processing, we work on regulation first before the cognition. So calm brain learns better, stress blocking learning, and safety enables growth. So stress comes from environment. What we are doing in IDHA, first of all, handling parent stress, handling therapist stress also, unrelating it with the age milestone and everything. So giving them calm environment, no stress. So and save and keeping child's motivation in front, not working on their weaknesses directly, working with their strengths, giving them confidence, reinforcing them. So stress blocking learning, calm brain learning, and safety enables growth. So a stressed brain cannot learn. IDHA prioritizes regulation before teaching. Once the brain feels safe, learning happens naturally. Sensory integration and primitive reflexes. So sensory seeking and avoidance, children are modulation strategies we teach them, and daily sensory diet we plan. So within our IDPs, we create sensory diets. Each child sensory profiling is done before IDP in first 15 days, and create the sensory diet which we provide to the children on a daily basis. We look for whether the child is sensory seeking or avoidance. So sensory behaviors are self-regulation attempts, IDHA does not suppress sensory needs. We organize them. A planned sensory diet reduces meltdown and improves attention. Primitive reflexes, we look for retained reflexes, impact on posture and attention if there is any, and integration exercises we create for them. So primitive reflexes should integrate in early childhood. When retained, they affect their balance, coordination, and emotional control. So IDHA includes reflex integration as a foundation for higher skills. Then comes the area of social development through exposure. So social skills are developmental. They can be developed, not scripted behavior. So we don't script the behavior that you are supposed to do this. We are going there. You are supposed. Many a times parents do this. Now I'm taking you to the shop. You are not supposed to ask for chocolate there. You will not get chocolate. These instructions, scripted behavior is not given to the child. Rather, social skills are taught. Real interactions are taught. And gradual exposure to different environments, social environments. So they learn socially. So social skills are not taught, they are experienced. IDHA uses peer exposure, group activities, and real life interactions. We don't force eye contact, we build comfort. When a child has comfort, automatically child gives eye contact. ADL, vocational and basic education. Activities of daily living, vocational trainings, and basic education. So our focus is on independence. Yes, right from day one, we work on independence, daily routines, and life skills. Independence is dignity. A child who can do his own things is more confident, is more, on dignity level. He's higher. So IDHA prioritizes ADLs because independence reduces anxiety. Independence builds confidence. So we look for child's routine from morning till evening to a 200 task list. And from those 200 tasks, what all child can do, we just tick mark, yes. So we practice them. And what child finds difficult, we simplify and start teaching those things with the help of what child can do in continuation. Each task, that's called, there is a process of task analysis. So each task we need to do task analysis. Brushing the teeth. If you do the task analysis of brushing the teeth, you can make 20 tasks out of it. Going to the washroom, opening the washroom door, finding where the toothbrush is, finding where the toothpaste is, holding the toothbrush, and opening the lid of toothpaste tube, then applying the toothpaste on toothbrush, then again closing the lid, then putting the toothpaste in the mouth with the brush, and then rubbing it inside, gargling with water, opening the tap and closing the tap. Like this, you make list of tasks which are involved in one thing, brushing the teeth. And then teach one by one, simple. What child can do? Think of that. From these task list, which task is connected to what child can do? Child can open the bottle and drink water. Then child can definitely open the tube and apply paste also. So opening bottle, opening a tube are similar tasks. So I connect with what child can do and what are the common tasks from this task analysis. I start from there and then add on. So activities of daily living are taught like this. Vocational training, strength-based roles, skill matching, and functional productivity. So vocational training comes at a little later stage, but we look for the child's strength and work with strength-based roles. Then skill matching, whatever skills child has and this training, this particular task, what we are trying to teach the child is matching. And functional productivity, that is also very important. So every child has the right to meaningful work. IDHA introduces vocational thinking early, not to label, but to prepare children. So prepare children for vocationals. So earlier they learn, they are more experienced and they are more proficient into that. But remember this,
Dr. Alok, we can't hear you, sir.
Now am I audible?
Yes, sir. Thank you.
Yeah, thank you. So I was asking you a question from you. What is functional productivity? Anyone can answer this? What is functional productivity? Vocational training, whatever we are trying to teach to the child, that should be functionally aligned. Tina has written, if a child screams, react, will screaming back, respond. Okay, that is for the previous question. Okay. Sorry, I had not seen before. I'm just seeing the chat now. So functional is whatever we are planning for the child as vocational training should be matching to the functional skills of the child and should have productivity. It's like old dated items, still we are continuing candle making, envelope making, or such activities in name of active vocational training. Most of the therapy centers are providing these trainings, not therapy centers, sorry, vocational training centers. But they are not productive these days because this is the time of machinery, computer. So those things are being produced. Envelopes, we are not using much of envelopes now. So those things are irrelevant. They are not very productive. So we need to look for the trainings which can be like which children can adapt, matching to their skill and strength based roles. Same time, it should have some productivity into it so that they can make it as their own livelihood in future and start early. We don't have to wait for child to be 18 years to start vocational training. I can start vocational training at the age of 6 and 7 also, 8 also, depending upon developmental age of the child. I can start. I don't have to wait. Diet and holistic support, which is really missing from the regular traditional therapies. So gut-brain axis, the connection, nutritional balance, individualized plans for diet, and lifestyle balance are very important for a child's development. For any human being development, it is important. But for a child's development, these are very, very important. Many of the complaints, concerns are related to diet and nutrition. But still, we do not want to go to a dietitian. Just follow whatever is available on social media or whatever some other parent have told us. We just follow that. Each child has a different digestive system and their gut brain axis is different. So we need to understand first from a practitioner. So in IDHA, we at the time of assessment itself, we include diet and nutrition. We check the child, we do the assessment from dietitian, and you change the diet as per the need. So nutrition directly affects attention, mood, and sleep. Please understand this. So with food also you can work on a lot of concerns. So nutrition directly affects your attention, mood, and sleep. IDHA does not follow trends. We individualize. So we don't follow, okay, start with GFCF diet. Okay, don't give sugar if child is hyperactive. I give sugar to children who are hyperactive and they don't become more hyperactive. Depending upon when you are giving it, what time you are giving it, all those things need to be looked at. Quantity, in which form you are giving it. So we don't follow the trends, general trends. We individualize as per each child. In IDHA, we do the diet and nutrition assessment as per child needs, as per child concerns, behavior patterns, all of this together, as per child profile, we create diet and nutrition. But our diet and nutrition in IDHA is very simple as per family standards also. Whatever they eat at family, whatever is we don't ask them to buy, special foods or super foods or spend a lot of money. We give them small things which are available at their home, culturally, whatever their culture is, whatever their eating habits are, accordingly, we give them solutions. A nourished brain regulates better. So food for brain also, like, a nourishment for brain. So nourished brain can regulate better. Naturopathy and holistic healing are complementary approaches. We use them. It helps in stress reduction and whole body wellness. So we give them sometimes, we include during this small naturopathy massages, food also naturopathy food, diets of related to naturopathy we give them. So holistic healing supports, not replaces therapy. So it just supports. It is not replacement of a therapy. IDHA uses evidence-informed complementary approaches responsibly. Then comes pet therapy and research-based intervention. So in IDHA, we use pet therapy also. It helps in emotional bonding, social initiation, and anxiety reduction. But depending upon family values. Some families are, culturally, some people are, against keeping pets or particular pets they need to keep. So accordingly, we modify because our IDHA plan is individualized plan. Animals offer unconditional connection. For many children, pets become emotional bridges to human interaction. That's all of the approaches, all of the club to, the principles and approaches club together that comes in IDHA. Any questions so far?
Sir, around vocational training, like, can you suggest some different things? I have also seen now people are thinking of introducing vocational training to children who cannot do well in academics, for example, children who have learning disability along with autism. So they are training them into crocheting, into stitching, other things. So, are there any other suggestions from your
Yes,
side?
there are suggestions they can make. They can easily and happily. We are trying that, and they are doing it. They can get into making pickles or pre-cooked food, package and sell it in the market. It's in every location has demand of it,
Great.
and they are easy. They are easy to make. Simple recipe. People are looking for homemade food these days, homemade recipes these days. So make homemade pickle. They don't have to do much tasks also in that. We can provide support wherever is required. So like cutting, chopping support can be given if child is not able to do it. But at least mixing the masalas, quantity, and packing it and selling it in the market. That all, and it is sellable at even at corner of your house. You don't have to go and find big markets for it, right? Another
Yeah.
another thing would be if child is depending upon child needs. Now we are training a child on computers. So let me tell you, I think I've told before also in some of the sessions, we are currently working on a project that is called Spandan Snehevatika. So Snehevatika is garden of love. So we are working on this project as a village resort, a commercial project. It's not NGO project. Though it is an NGO project, but it is commercially viable project we are trying to make. So this place is going to be a village resort where people from Mumbai or nearby cities can come and stay there for weekends, for their birthday parties they can host, or they can come there for 2 days, 3 days. We are giving them eco-living concept, and the whole project will be managed by special children. Children who are at Spandan, children as in they are adults, but adults of Spandan inmates will manage the entire project. So accordingly, we are training them. 2 children we are training in the kitchen, they will take care of cooking. 1 child we are training on service part. One is being trained on computers for billing. So billing software and all we are teaching him, menu reading, calculating the menu, from menu picking up the item code and putting in the computer and calculating. So likewise, 2 children we are putting in housekeeping. So they will be taking care of cleaning and housekeeping. So depending upon their interest, we are building this whole concept. So they can be employed. They can earn their livelihood. and live in a controlled environment, organized environment, and supportive environment. And USP of this project is going to be that people will come there because Spandan children are managing it. So that can be done. Nowadays, we are seeing cafes and small restaurants are appointing these people. So that can also be done. And if you
So
see,
doesn't it put these children at the risk of some vulnerabilities? Like these children can be abused easily.
yes,
Mm.
that's why I said we are developing it, and children will stay in a controlled, organized environment because we will be there. Our staff and people will be there involved in the process. We are not just going to hand over this project to them and they will run it. So definitely they are going to work under the supervision, guided supervision. And this is a small project. Snevatika is not a very huge project. We are just constructing 4 huts to start with.
Sir, where is this Spandan?
Spandan is in Mumbai, outskirts of Mumbai. It is there's a place called Safale, which is close to Virar in Mumbai. It is there.
Sir, anything you know in Hyderabad?
Autism ashram is there, but price-wise, if you see, it is little costly. Autism ashram, Dr. Kundra's.
Okay.
Yeah, you can search it on Google. You'll easily find it. They have started one in Ahmedabad, also close to Ahmedabad, in Gujarat, also somewhere. That's in outskirts of Hyderabad. Autism ashram. You can search.
Okay.
One more is coming up in Kolkata. If somebody wants to know, India Autism Center, they are also that is also run by a parent. It's coming up now. They have just started, but on a very big scale, they are coming up. So IDHA philosophy now. It's a unified vision. As I said in the very beginning of slides, we work on developmental over diagnosis, connection over correction, and independence over compliance. IDHA is not about doing more. It is about doing what matters and together. So what matters, we are just concentrating on that. Functional goals, ADLs, we're concentrating on that. And as one of you just now said, children who are not good at academics, we are training them for vocational. It is not necessarily that everyone has to be good at academics. If child is finding it difficult to be good at academics, we teach them only basics of academics. And we give them functional trainings. They can do very well in functional. Not that everybody has to be doctor and engineer. Okay. So parents need to accept it. I am struggling with one of the adult patient who is like from very early. He was like 3 years since that time I have been involved with that child, and parents are also close to me. It's like, but still struggling because parents are, in spite of 20 years, very kind of sound education background parents have, but they are comparing this child with the cousins of this child and they want this child to do an MBA, and child is struggling with this. So acceptance needs to come that not that everybody has to be MBA. People are doing much better in their career, financially also doing much better, even without doing MBAs too. So if they find the right direction, we need to look at their strength and give them. And even if they are not earning much, it's fine. Parents should prepare financially and things so that children can lead their life. So it is about doing what matters rather than putting the child under stress and doing it together. When professional align, parents believe and children feel safe, development automatically follows. So we need to work on professionals alignment, parents belief on us, and children should feel safe with us. They should feel connected, safe, enjoy with us. Development automatically will follow. So that is the vision of IDHA, which we work on. Integrated model is all domains are connected. And key takeaways is IDHA is child-centered, parent-empowered, and development-first therapy approach. So I hope you have understood IDHA philosophy. You can apply IDHA in real clinic, home, school settings. You can think developmentally, not mechanically now onwards, and can work collaboratively with parents and teams. That is my expectations after this session today. Autism management is not about fixing a child. It's about understanding, supporting, and empowering a human being. So we are in autism management, we are not fixing a child, we are understanding, we are supporting, and empowering. We are looking at a child as human being and we are supporting. That's all about IDHA. I'm open to the questions now. I hope you all can relate with it, find it interesting. Even if somebody has some critics about it, please do share with me. I'm open.
As you said, it is everyone look at the problem in the same way and find a solution for it, especially for the child. Okay, this is what we follow in the school for normal children. So we call it as integrated learning. So we have take a topic, and the same topic is covered in English, math, language, and other things. So the same topic in various ways it is being brought in so that the child understands. So I can relate it with what you were conveying. So 100% this will be more successful if it is being taken in a right way.
Yes, I agree with you. Thank you so much. Yes, integrated learning, or as I gave you the example of multi-specialty hospitals, also integrating management of the diseases. So this is the same approach. There's nothing new in it.
Yes.
As I want. There's nothing new. It's just that focus is shifted elsewhere. We are working towards, and stress is released, minimum of work, and taking support from parents, involving them in therapies, all of this, parent counseling, all of this combined together.
Yeah, and as you were telling, sir, saying that the first 15 days will be for the observation to see it's a play way where the child is settling. This is what we do when the child enrolls, the parent enrolls the child in into a toddler or a pre-KG program. So when they come in, we tell the parents, see, admission you can do it, but we need to say how the child is settling with us. So I can relate it so well, and it's no different. So it was quite an interesting session, and we are so glad that you have come with such a beautiful program, and I'm glad about it.
Thank you, ma'am. Thank you.
Sir, I have one more question.
Yeah, please.
I'm in Bangalore. If I had to start my own center, what are the procedures? What are the pros and cons for it? Is it okay for me to talk now, or is this not the right platform for me to talk?
No, of course, this is the right platform, not a problem. But I would like to speak to you in person about it because I want to understand. First thing is, I want to understand where from this thought is coming and why do we want to start a center. I have seen many of the parents starting a center and failing into it.
Okay.
So I want to just first understand why we want to start, because as a parent, when we struggle with therapies, we run here and there, or when we have to sacrifice with our career for this child, we feel that we want to be in this field and we want to start our own center. Okay.
Yeah.
And then we start. But running and managing a center is again cost.
A challenge.
Yeah, it's a
Challenge
challenge
and a
because
cost.
it is cost and challenge, of course. So then with time it becomes difficult. And many of the parents I've seen that they have closed down, and many are running very successfully as well, both the areas. So I'm not discouraging you. It's a wonderful thought if you want to start. And I would love if you start a center and we work together on with this IDA approach, because you are already practicing it. So if we work together with this approach, I am sure this will bring a lot of change in children. But we need to probably discuss separately and then plan.
I will call you, sir. If you can
Yeah,
give your convenient time, I think so I can.
no problem. You can just text me, ma'am, and we
Yes.
can discuss. We can fix up a time for tomorrow, day after tomorrow, any day.
Yeah.
Today it's like I have a session 5 to 7 and then webinar at 8 o'clock. So today won't be possible. Tomorrow we can discuss, no problems, anytime.
Thank you. Thank you so much.
We have a program also, CDFC, not CDFC. That is, I'm missing the name of the program. That is especially for pediatrics rehabilitation center management program.
Okay.
So that is for the people who are running their own pediatric center or who are willing to start their center. That speaks about everything about pediatric rehabilitation center except therapy. So the program does not include therapy, but it speaks about marketing, branding, legal framework, infrastructure, what to start, what not. So that is available in the recorded mode also. We can share that with you. So you can probably connect with me or Monira, and you can see that. So that will also give you insights of what all infrastructure is
Thank you,
required.
doctor.
And I'm there
Thank
to support anytime. Bangalore, I have a lot of
Thank
professionals also I'm connected with. So I'll support you. I'll ask you to integrate with them. It will help. Okay.
Thank you, doctor.
Okay. Any other question for me?
Questions
Anyone?
are not there, sir. It was a very practically approaching, like we can approach practically in schools also, inclusive schools, especially I was thinking at that time for every child, because every child is different. So many things out of this can be used there in that setup. That's what I could say.
Yeah, we have started using it in Angel Special School in Mauritius for
You
almost,
mentioned earlier.
yeah, almost 7-8 months. Since last year March, we are using it. Last year March, we started using it.
Especially toddlers, all are different.
Yeah, and we are seeing wonderful results. Now we are starting in February. We are starting. Vanisha is here. I think Vanisha is not here in this session. So we are starting with Angel Special School. We are starting another setup of autism center, a rehabilitation center, same like Spandan we have in India. So in February, infrastructure is going on right now. In February, we are starting an autism rehabilitation center, residential center in Mauritius also.
Mauritius, okay.
Yes.
A lot of work is being done there.
Yeah, infra is going on and a lot of work has been done. Yes. So Vanisha is one of the participants of some programs. She is, her husband is the director there of school, and together JKP Care Foundation and Angel together is working on that. So yes, as you said, this model is helping us in the school as well. It is helping us. Okay, thank you then. Thank you everyone.
Yes, thank you very much.
I'll get a break now for half an hour.
Thank you so much, Dr. Alok. Thank you.
Thank you, Bobby.
Thank you, doctor. Thank you,
Nice to
doctor.
see you. Nice to see you, Bobby.
Pleasure to see you again, Alok. Good listen to you.
Yeah, evening we have webinar, Bobby. I've sent you the link also. Yeah.
Okay. Thank you, Dr. Alok.
Thank you. Yes, Neelam, you wanted to say something? Somebody was saying something.
Sir, I had a same query just as Miss Sudha was saying, opening a center. So I would also like to take an appointment from you. Need to discuss certain things.
Let's do one thing. People who want to start their own center, let's fix up just WhatsApp me. Let's fix up a common time. We all can connect on Zoom, and for 1.5, 2 hours, we can discuss in detail together. That would solve.
That should be absolutely fine, doctor.
Yeah. Yeah.
Good idea.
Yes, sir. That's
good
fine.
Idea. Thank you, doctor.
Sure. So what I will do is, sure, Meena. Just text me on WhatsApp that I am interested to join this session on opening a center. I'll create a WhatsApp group for all of us who wants to start the center, and then we will start discussing. We'll fix up a Zoom meeting. We'll discuss there. Surely, we'll do that.
Okay, sir.
Thank you, sir.
Thank you.
Thank you. Have a wonderful week ahead. Take care. Bye-bye. This presentation I will share. So try to start using these approaches. If not fully, even if small approaches you can start implementing in your regular practice, it will help us. Good luck. Bye-bye.
Sure, sir.